Welcome to the deep dive. We've got a fascinating set of sources you send over, looking at something pretty hidden, but absolutely critical in the UK's NHS.
That's right. We're talking about clinical coding.
Yeah, this mandatory process, it basically translates everything that happens to a patient, diagnoses, procedures, you name it, into standardized codes. Things like ICD-10.
ICD-10 for diagnoses, OPCS-4 for procedures, exactly. And these aren't just for records.
No, they're the absolute linchpin for hospital funding, right, through these HRGs.
Healthcare resource groups, yeah. They determine the income hospitals get. And critically, they also form the basis of, well, all national health data and planning.
Okay, but here's the hook, the really shocking part from these sources. The error rate in coding, the main reason someone's discharged, it can be as high as 31%.
31%. It's huge. And it points to this really deep systemic crisis. It hits finances, data quality, the workforce, even governance.
So where do errors that big actually come from? It seems too high just for typos.
Well, you'd think it might be the coders, but the sources are quite clear. The fundamental problem, it's the raw material they work with.
You mean the patient's actual medical record?
Yeah,
The notes?
exactly. The quality of that clinical source documentation is often lacking. That's the core issue.
And the numbers on why it's lacking are pretty stark. Illegibility, just messy handwriting or unclear entries, is a factor in over 91% of coding errors.
91%.
Yeah.
And think about incomplete notes or ambiguous terms. That hits 80% of the cases reviewed in one study.
So the coders are left trying to decipher things.
Right. And that puts an immense cognitive load on them. They're often forced to infer what the clinician meant, which technically they shouldn't do. It violates coding standards.
And there's pressure, too. Staff shortages.
Massive pressure. Chronic shortages mean nearly half, 48%, admit they sometimes only use the discharge summary.
Not the full notes.
No, which hugely increases the risk of getting it wrong, omitting details. It basically shifts the quality control burden entirely from the clinicians onto the coders.
Okay, so poor notes lead to coding errors. And that, presumably, hits the bottom line, the financial side.
Directly. That's the second big crisis area. Bad coding, especially undercoding, means hospitals don't get paid correctly for the work they did. It's an HRG under recovery issue.
And audits show this.
Yeah, clearly. One audit found that just correcting coding errors led to an average revenue increase of 209 hours per patient.
Wow. 209 per patient. Scale that up nationally. That's a major financial bleed.
Absolutely. And this financial pressure then feeds straight back into the workforce problem.
How so?
Well, there's what the sources call a desperate national shortage of clinical coders. The pay often doesn't reflect the complexity or financial importance of the job.
Leading to burnout.
Exactly. It's a vicious cycle. Shortages mean huge workloads, pressure builds, quality might slip, and more people leave.
And it seems like oversight isn't catching this.
That's another point. Despite national standards requiring coding audits, one analysis found 40% reported. Well, basically no regular auditing of coding accuracy.
40% just aren't checking. Okay, so with all this human pressure and error, you'd think technology would be the answer. AI, new systems.
You would, and the NHS is moving towards newer systems like Snowman CT, which is much more detailed, and there's definitely talk of AI and natural language processing.
Yeah.
But the transition is tough. Trying to automatically map detailed Snowman CT terms back to the ICD-10 codes needed for billing, it's not straightforward.
Oh, not straightforward.
Well, one study looked at this automated translation. The amount of imprecise or totally missing codes was almost 66%.
66%. So it actually increases the work for human coders. They have to manually check everything.
Pretty much. It adds a huge validation burden.
So AI isn't the magic bullet right now. Why not?
It's definitely seen as a long-term goal, but the immediate hurdles are big. Organizationally, it's about trust and explainability.
You mean being able to prove why the AI chose a specific code for audit?
Exactly. And technically, we just don't have the huge UK-specific, expertly labeled gold standard data sets you need to train AI reliably for this complex task yet.
Right. Okay, so wrapping this up, what's the key takeaway for people listening?
It has to be a systemic fix.
Hmm.
You can't just blame the coders or hope AI solves it overnight.
So focus on the source. Improve the clinical notes.
That's critical. Mandatory clinical documentation improvement CDI programs seem essential. Fix the input. And frankly, the role of the coder needs elevating. Better recognition, better compensation for a job that underpins billions in funding.
And there's a wider context here too, isn't there? around risk.
Definitely. Think about clinical negligence. Clear, accurate patient records are absolutely fundamental evidence in those cases.
And the NHS faces, what is it, over 2.8 billion pounds a year in clinical negligence claims.
That's the figure, yeah.
So here's a final thought for you to consider. If poor documentation fuels coding errors and financial loss, and it weakens the defense against negligence claims, how much of that massive 2.8 billion legal exposure could potentially be reduced just by ensuring every patient's record is clear, complete, and accurate from the start?
Something to think about. Data integrity isn't just about finance, it's about patient safety and legal risk too.